Thank you very much. So these are my disclosures, none of which are relevant. So jumping right into this, this is the CEI approach to ocular surface treatment options for unilateral disease. And what we see is, once you have ocular surface failure, you have several options. You can either go for a CLAU, the modified Cincinnati procedure. Now maybe we can add SLET to this, although the data Dr. Holland just showed may not agree with this. And then moving on to the Boston K-Pro, that could be a possible primary thing, but with an asterisk. Afterwards, if they need it, there's a staged procedure of the optical keratoplasty, which again can be replaced with either a DULC, a K-Pro, or a PK itself, which you can then repeat. But as you can see, the key thing to look at is at all of these points, the K-Pro is an end. There's no more step after that. And that's part of the problem with the K-Pros, as I'll keep showing. So this is the possible treatment options for bilateral disease. And again, you have the living related, you have the Cincinnati procedure, a KLAL, a possible K-Pro. An alternative thing here is either something like allo-SLET, which is again, what we saw in the data may not be the best option. And again, you have to follow this up with another optical procedure, either a PK, DULC, and again, K-Pro. And you can repeat all those. And once again, the K-Pro is at the end of the tree, so there's no more options after that, which is something you have to keep in mind. So they have some advantages. And as we've mentioned a little bit, the ocular stem cell transplants have the advantage that they can be used for severe conjunctival disease, so when you have symblepharon, inflammation, and this is where the K-Pro is not positive, because you are able to bring in some conj, especially things like living related and autografts. You have easy IOP monitoring. It's just like any other case. You really improve the ocular surface, but you need that subsequent keratoplasty. The complications really result in the loss of the surface, not loss of the eye, because it is really an extraocular procedure. And the follow-up time can be reduced once the surface is stabilized. There are obviously some complications, some of which have been mentioned. You have to follow them up really closely. You need expert care, and you need to see these patients regularly. You need systemic and ocular monitoring. You need almost a perfect ocular surface for good vision, and you can get rejection. So as we showed, there's severe rejection and low-grade rejection, and all of those can actually happen. And also your PK, as Dr. Shah just showed, your subsequent keratoplasty can also fail. Looking at the Boston K-Pro, it definitely has its advantages. It's a single operation. It's not staged. It's technically similar to PK. It's something we're familiar with. There's no immunosuppression, no risk of rejection, and the poor ocular surface doesn't interfere with your vision. You still get a good result. However, there are definite disadvantages, and that's one thing we're going to talk about. You can't measure the IOP. You have to usually use your finger or something like that. You're not going to get accurate IOP follow-up, lifetime close follow-ups, lifelong close topical antibiotics, and you can get complications that lead to corneal melt, infectious keratitis, endophthalmitis. All of these, you'll lose the eye. You don't just lose the surface, it's the whole eye is gone. And probably the most important and one of the worst of these is glaucoma. And so this is data that from 2012 and 2011 from multiple centers showing the rates of glaucoma. And the key data I want to show you is the glaucoma causing visual loss. And at the CEI study, 47% lost 2 lines. At the UC Davis study, 54% weren't able to retain 2200 vision. And more data has actually made the story even worse. So as we've looked at, other studies have looked, glaucoma progressed in about 16 to 21% of the patients, depending on what study you believe in. And 2 studies from 2017 showed progression in 27%, newly diagnosed in 8%. So this is you put in the K-Pro and you're getting progression of glaucoma. And there was a second one, they said, well, why don't we try putting a tube shunt in when we do the K-Pro? And they showed that while it's safe, there's no adverse effects, it didn't change the rates of glaucoma or the visual outcome, so why bother? So when you're putting in a K-Pro, you have to consider that, this is not something you want to put in a young patient. Don't expect 50 years of vision. Even beyond 10 is questionable. Even worse, you have to remember that the K-Pro studies you see out there don't include, are a heterogeneous group. So they have severe ocular surface disease, but most likely they have things like multiple rejected grafts and things like that. And when you put K-Pros in patients with severe ocular surface disease, they do much worse. So they get more melts, more infectious keratitis, more endophthalmitis. So when you're looking at a K-Pro study, don't forget that. You have to really compare the same population. So if you want to think about the ones with more severe ocular surface disease, those are going to have more complications. The only kind of study that's been done compared head-to-head is one we presented in 2012, really comparing OSST versus K-Pro for anaretic keratopathy. What we did see is while the K-Pro did have a greater than 2-line improvement in visual acuity compared with the OSST, it was not statistically significant. And similarly, the post-op visual acuities with the OSST group were better than the K-Pro group, but again, this was not significant. So the ideal patient for an OSST is someone who's young, middle-aged, in good overall health, and really able to comply with the extensive follow-up and lab workup that's needed. There's no real contraindications to immunosuppression, so what are those? Really, you can't have malignancy for 5 years and none of the significant comorbidities. The glaucoma should ideally be controlled either with a tube shunt before the OSST, and they should have reasonable lids. You want their lids to be able to close really before you do this. For the K-Pro, you want the extent of the ocular surface disease to be quite minimal. You want an intact fornix, you want to have a good ability to wear those contact lenses to prevent melts, good conjunctival function, and really absence of severe dry eye, as that's going to give you your problems later on. You have to be able to comply with frequent lifelong follow-ups, as well as topical medications. You definitely can't have glaucoma, especially severe glaucoma, and you want someone who's an older patient. So in conclusion, both of these options are successful treatments for severe ocular disease. Each has its own indications and benefits, and what your role as ocular surface surgeons is not really to decide which is better, but which one's more appropriate for your patients. Thank you.
Thank you very much. And then the final